about was the American College of Obstetrician and Gynecologists, American College of Cardiology, American Heart Association, third, the European Society of Cardiology, European Society of Hypertension, and the National Institute for Health and Care Excellence. First, the classification of hypertension during pregnancy was different between the American College of Obstetrician and the European Society of Cardiology in that preeclampsia, eclampsia, chronic hypertension of any cause, chronic hypertension with superimposed preeclampsia and gestational hypertension, while in the ESC guideline mentioned the pre-existing hypertension, gestational hypertension, pre-existing hypertension plus superimposed gestational hypertension, preeclampsia, and the fifth one was antenatally unclassifiable hypertension. In 2019, the American College of Obstetricians and Gynecologists published updated guideline on the diagnosis and management of chronic hypertension, gestational hypertension, and the preeclampsia. First, they recommend that prevention of preeclampsia is the first goal, and American College of Obstetricians and Gynecologists outlined recommendations for the use of low-dose aspirin for preeclampsia prophylaxis in a separate committee opinion published in 2018. Aspirin, 81 milligram, is recommended for high-risk women between 12 and 28 weeks gestation until birth. Also, they define chronic hypertension as hypertension diagnosed before pregnancy or before 20 weeks of gestation with a blood pressure equal or more than 140/90 millimeter mercury on at least 2 occasions 4 or more hours apart. While the new diagnostic criteria for stage 1 hypertension, according to the American College of Cardiology, that stage 1 hypertension 130/139 and diastolic 80 to 89, the American College of Obstetricians and Gynecologists said that the state that the significance of these parameters in pregnancy is not certain. So they regard elevated blood pressure as stage 1 hypertension according to the American College of Cardiology as a pre-hypertension, and hypertension start 140/90 and above, while severe hypertension was 160/110 and above. Also, they recommend maintaining blood pressure less than 160/110 millimeter mercury with labetalol and nifedipine, the two first-line oral agents for long-term control in pregnancy, while methyldopa differ to be last in the treatment lines. Also, American College of Obstetricians distinguished gestational hypertension from preeclampsia. Gestational hypertension is defined as a new onset hypertension with a blood pressure equal or more than 140/90 on 2 occasions at least 4 hours apart after 20 weeks of gestation, while preeclampsia is hypertension with proteinuria or other end organ effect. European guideline said proteinuria must, but in the American guideline, proteinuria or other end organ effect include thrombocytopenia, renal insufficiency, or impaired liver function, transaminase greater than twice normal, pulmonary edema, and the new onset headache unresponsive to medication or visual symptoms. All these regarded as end organ effects. In both chronic hypertension and gestational hypertension, American College of Obstetricians and Gynecologists recommend antihypertensive medication when blood pressure equal or more than 160/110, with goal of blood pressure to be below this threshold. Intravenous hydrelazine and labetalol and the oral nifedipine are recommended for acute hypertensive urgency, and oral labetalol and calcium channel blockers are recommended for long-term control. This is the antihypertensive agent used in pregnancy. Also, they recommend specify that outpatient management is an option for women diagnosed with gestational hypertension or preeclampsia without severe feature dependent on adherence to frequent outpatient visits. Hospitalization is recommended also until delivery for those with severe disease and organ damage or severe hypertension, and for those who cannot undergo close outpatient monitoring. Also, they recommend that fetal growth ultrasound measurement every 3 to 4 weeks, measurement of amniotic fluid at least weekly, and antenatal testing once or twice weekly to detect the complication of hypertension regarding fetal growth retardation. Delivery is recommended according to the American College of Obstetricians and Gynecologists at 37-week gestation for women with gestational hypertension and preeclampsia without severe feature, while if there is severe feature, it is 34 weeks, the time of induction of labor. Indication for earlier delivery, earlier than 34 weeks, include uncontrolled severe range blood pressure, refractory headaches or upper abdominal pain, visual disturbances, stroke, myocardial infarction, HELLP syndrome, worsening renal dysfunction, pulmonary edema, eclampsia, or fetal distress. All these are indication for early delivery of the fetus to save the mother. Magnesium sulfate is still recommended for women with preeclampsia with severe feature and for prophylaxis during labor and delivery, and continued until 24-hour postpartum. While the American College of Cardiology, American Heart Association at 2017 makes 2 specific recommendations for treatment of hypertension in pregnancy. They said first, women with hypertension who become pregnant or are planning to become pregnant should be transitioned to methyl-dopa, nifedipine, and or labetalol during pregnancy. Here methyl-dopa was mentioned. Second, women with hypertension who became pregnant should not be treated with angiotensin-converting enzyme inhibitors or angiotensin receptor blocker or direct renin inhibitors due to their side effect on the fetus. The guideline states that the reasons for antihypertensive treatment during pregnancy are twofold: to prevent severe hypertension and to potentially prolong pregnancy for fetal benefit.
Sorry, Dr. Imad, تبقى وقت 2 minutes.
Okay. According to the American College of Cardiology, systolic blood pressure should be less than 140 millimeter mercury target. While European Society of Cardiology at 2018 makes similar recommendation to the American College of Obstetricians and Gynecology, but variation include recommending higher dose of aspirin, first 100 to 150, and initiation of antihypertensive treatment if blood pressure persistently equal or above 150/95. They suggest target blood pressure less than 140/90, noting that the optimal blood pressure target in pregnancy is unknown. They recommend Doppler for fetal growth retardation. They recommend methyl-dopa first line with labetalol and calcium antagonist for the treatment of hypertension in pregnancy, and IV labetalol or oral methyl-dopa nifedipine for severe. Hydralazine is no longer the drug of choice according to the European Society of Cardiology due to its adverse perinatal effect. Use of IV Rapidil can be used. Sodium nitroprusside differs to the last of the list due to its side effect, including fetal cyanide poisoning. The drug of choice in preeclampsia with pulmonary edema is still nitroglycerin and IV. This European Society recommendations. The national NICE recommendation, the same recommendation, but differences include antihypertensive therapy for women with chronic hypertension, more or equal to 140/90. Women with gestational hypertension and preeclampsia not already treated should be offered medication for allowing birth if a blood pressure equal or more than 150/110, and target blood pressure according to the NICE it is less, 135/85. And the new studies published in this year, the CHOP study, go with NICE recommendation that blood pressure, even mild chronic hypertension, every must be treated, and the goal may be changed in the few years later. This the aspirin recommendation difference between guideline from 75 milligram to 150 milligram. This is the risk factor. I will pass rapidly. and it's a high risk factor for, according to the guideline, high and moderate risk factor for developing preeclampsia. This is the when to start treatment during pregnancy according to different guidelines, and the target blood pressure according to different guidelines.
Sorry, consultant Imad. بس conclusion. Thank you. Thank you, sir.